Yes, I just want to disclose some royalties that I get from QMP, and I give some advice to Polytech and to Julep. So I have already shown this slide, how do we age sagging, wrinkling, volume loss, contraction, and loss of animations. Those are all components that are part of aging in our patients. So the max lift is our workhorse, the minimal access cranial suspension lift, and it's a short scar facelift, which is based on suture suspension of the SMAS without SMAS undermining. And basically we use either three loops, which has actually brought facelifting from a tightening procedure to a more subcutaneous sculpturing and redraping procedure. So the simple max lift, which is actually the version that we use the most, corrects the lower half of the face and the jowls, and the marionette grooves and the corners of the mouth are also lifted with these two sutures. Mainly the second loop is taking care of the jowls and the corners of the mouth. So as an example, this 49 years old lady, she mainly complained of some incipient jowling and some laxity of the submental area. She also had some bulging of her lower eyelids. So we treated her with a simple max lift and a transconjunctival fat resection and periorbital erbium laser resurfacing. So this is the result, and as you can see, that has allowed to restore the facial oval and the nice and crisp jawline, and also the cervicomental angle. Also, when the patient is looking down, that actually shows how powerful this max lift suture can restore the cervicomental angle. And it is stable over the years, so this is a 6 months and 5 years result. So you see that the lower half of the face stays corrected, the jawline stays crisp, and the cervicomental angle also stable over years. And the way that it actually works is that the aging of the neck comes down to an elongation of the auriculoplatysmal ligament. This is a ligament between the base of the auricle and the cranial border, the lateral cranial border of the platysma. And Daniel Labbé from Marseille has pointed that out, and he has shown that you don't need to undermine under the platysma to get a good correction of the cervicomental angle and a redefinition of the sternocleidomastoid border. You just need to vertically lift the cranial edge of the platysma, and he anchors it to the Lore's fascia, but basically it comes down to the same principle as what we use with the max lift. Now the important thing to remember here is that if you want a stable correction of the neck and a stable suspension of the platysma with the max lift, is that when you make your first suture loop, you really want to take at least 2 or 3 solid bites in cranial border of the platysma so that you get an effective shortening of this auriculoplatysmal ligament. This is a very important point. And so the extended max lift, which we also described, had a third loop, which was intended to better correct the deep upper nasolabial fold and to also lift the descended eyelid to cheek junction. And as I have already showed you, this did indeed work well. So you get a lifting of the mid-cheek volume into the upper cheek and the shortening of the lower eyelid and a better blending of the eyelid to cheek junction. But we have a shift of indications recently. So whereas previously we almost did all our patients with an extended max lift, nowadays we do microfat grafting in nearly all of our facelift cases. So 95% of our patients will receive a simple max lift, which will correct the lower half of the face, but the mid-face deflation is then corrected with microfat grafting. That doesn't mean that there is no more place for lifting of the malar fat pad. So you may still encounter patients with a true ptosis of the malar fat pad. And so in these cases, we're going to lift this malar fat pad, but most of the times we also do additional microfat grafting when indicated. So initially in the old days, when we were talking about facial rejuvenation, it came down to basically a neck lift and a blepharoplasty. Facelifting was very much focused on correction of the neck and the jowls. But you have to realize that facial expression is not in the neck. Facial expression is around the eyes and around the mouth, not in the neck. You don't communicate with someone from profile. You communicate in frontal view or sometimes in three-quarter view. So basically, if you want to improve the gestalt of youth, you want to focus on the centrofacial aspect. And so this little slide here illustrates this very well. All facial expression is in the center of the face. So modern facelifting, I think, should focus more on centrofacial rejuvenation. And we now realize that aging for a big part is deflation. As you can see in these sequential photographs of aging of the same lady, you see that she has deflated in several key areas as the infraorbital triangle and the malar eminence. She lost volume in the prejowl sulcus. She has lost volume in the upper eyelid sulcus and also in the temple area. Now, you can find this little video on YouTube, and it is very interesting to get an idea of how a face ages. It has actually been composed by 4 generations of the same family who were artificially morphed into each other. But you see that there's actually very little descent in this face. There is a lot of deflation around the eyes and around the mouth. There is actually very little descent, except for perhaps in the lower face area. So the first hypothesis that I want to give here is that midfacial aging is more a deflation phenomenon. And midfacial ptosis most likely is an optical illusion for a big part. Now, to illustrate this, I artificially separated sagging from deflation. And you see that the sagging of the face is a peripheral phenomenon, which is taking place in the peripheral part of the face, causing jowling, causing descent of the corners of the mouth. And the only central part of the face that actually elongates is the upper lip. So if you then consider artificial deflation, you realize that deflation is all happening in the center of the face. The only lateral or peripheral area of the face which deflates is the temporal area. So that means that in the lateral part of the face and in the neck, lifting is what you need, but in the central part of the face, you will need to restore the volume. So deflation mimics descent, where you realize that the eyelid to cheek junction doesn't descend. It's the midface that has deflated. Also, his upper eyelids are subject to deflation, and it's only in the peripheral part of the face that there is true descent. So again, it's not what you look at that matters. It is what you see, and we are only used to see what our mind is prepared to comprehend. We have to learn to look differently at our patients. So centrofacial aging is much more about deflation and much less about sagging. So if mid-facial aging is deflation, the treatment is filling. And as I said, mid-face lifting techniques may become obsolete as a rejuvenation procedure. So fat grafting, I think, is absolutely essential and an essential addition to rejuvenating surgery in the eyelids, in the malar area, and in the perioral area. And it has to come into our armamentarium so that we can create synergy by combining the right tools, and so that we will obtain a much better result than the separate application of these tools. So the areas where we almost invariably will add fat in any rejuvenating case are the upper eyelid sulcus, the tear trough, the malar area, the lateral malar area, are the nasolabial fold, the marionette groove, the prejowl sulcus, and also we inject the deepest rhytids with microfat with the sniff technique, the sharp needle intradermal fat grafting technique, which I talked about 2 days ago. Second hypothesis is that periorbital aging is also a deflation phenomenon. So the problem with traditional blepharoplasty is that it creates hollowed, excavated, empty eyelids, whereas a youthful eyelid is full, is crisp, is rarely hollow. Aged people have hollow eyelids, and that's the nursery home look, which was mentioned earlier this morning. So in periorbital rejuvenation as well, we're looking at a paradigm shift from resection to filling. And we have written about this in an article in the ASJ in March 2013, and called this augmentation blepharoplasty as a contrast to resection blepharoplasty, which was what we have been taught in our residency. So centrofacial rejuvenation is what we consider, and that involves fat grafting in 95% around the orbit in the augmentation blepharoplasty concept, and the perioral replenishment. And that addition with sharp needle intradermal fat grafting and nano fat grafting. Now again, it makes no sense to try lifting an empty space. I have shown you this patient this morning, and she is deflated in her midface, so there's no use in trying to lift anything here. You might have an effect early on in the postoperative period because there is a lot of swelling, but when the swelling goes down, most of the time these results are disappointing. And in the Caucasian patient, you're going to find that 2/3 of the volume that you need is in the part medial to the lateral canthus and only 1/3 laterally. You don't want to widen the face too much. You don't want to create a different ethnicity in your patients. So another example of midfacial deflation is in this patient. She presents at age 60. She looks very tired, very deflated. She was very full in her youth. And you can actually, she's a very nice illustration of the frame theory, which Tim Martin has described, and also Fahad Ben-Sliman, where you see that around the eye, in the youth, there is a very narrow frame, whereas in the aged person, the frame has widened as well in the lower eyelid as in the upper eyelid. So the intention would then be to narrow again that frame around the orbit. Again, there is very little descent in this face, except for the upper lip, except for the corners of the mouth. So this is her result after a combination of a max lift for correction of the lateral laxity and the neck, together with a temporal lifting to correct the descent of her, the tail of her eyebrows, and an augmentation blepharoplasty. The augmentation blepharoplasty involved fat grafting of the upper eyelid sulcus, of the tear trough, of the infraorbital triangle or the malar area, and also a perioral replenishment. She had fat grafting in her lips, she had laser resurfacing, and she had a lip lifting. And this is 1.5 years postoperatively. And I think this is a truly rejuvenative surgery. You can tell that the frame around her eyes has again been narrowed down to the exact environment of her palpebral fissure. In the three-quarter views, you also see that we have replenished her midface, her malar eminence, and that her lip has been lifted. And of course, she had some laxity, which has been treated with a facelift. The 65-year-old lady came to us 6 years. No, she came to us like this. I'm sorry, complaining of laxity and aging. So she was treated with an extended max lift, with an upper and lower classical blepharoplasty, and a lip augmentation with fat grafting. And this is her 6 years after her initial treatment. She came in because she was unhappy with the aspect of her eyes and her neck, because she had some recurrent platysmal banding. And she was right. She was absolutely right, because she didn't look really healthier or younger than she was. She looked tighter. That is sure. So we had to do something else in her to get a better result. So what did we do? We corrected her platysmal band with a platysmoplasty, and then just an augmentation blepharoplasty, fat grafting in the upper eyelid sulcus, the tear trough, the malar area, sniff in the perioral area, nanofat in her upper lid, and also some nanofat in the periorbital area, and in the vermilion. And this is her 2 years after this treatment. Hardly any surgery, hardly any incisional surgery has been done, except for the platysmoplasty through a submental incision. The rest is all fat grafting and a minor touch-up of the skin laxity of her upper eyelid. And here again, you see that the frame, which had not been treated in her initial blepharoplasty, has here been narrowed. And you can see the sequence from age 65, before any facelift or eyelid surgery, to 71, 6 years after that we treated her. And you see that the frame around her orbit was not treated. She was undertreated. She was not treated correctly. Whereas here, we have actually reduced the frame around her orbit and made her eyes look youthful again. I have shown you this patient this morning, just quickly again, to point out that the rejuvenation of the centrofacial area is, in most cases, in many cases, at least as important as the correction of the laxity. And that is also what Tim Martin is pointing out, that most of the patients don't just need a mid-face lifting, or don't just need a facelifting. They need a restoration or preservation of the harmony in the face. So you need to treat all the features of aging. So as I said, we should focus more on centrofacial rejuvenation when considering rejuvenation surgery. And centrofacial surgery, centrofacial rejuvenation comes down for the biggest part to a combination of augmentation blepharoplasty and a perioral replenishment. So the perioral rejuvenation is a combination of fat grafting, resurfacing in any way, and also lip lifting. How do we treat the nasolabial fold, which is also part of the perioral area? So we start by doing fat grafting perpendicular to the fold to build up a foundation, and then we continue with longitudinal fat grafting in a more superficial plane, And once that we have done that, we are going to subsize with a 16-gauge needle the dermal attachments of the nasolabial fold so that we actually create a cavity, a longitudinal cavity along the nasolabial fold so that the sharpness of the fold is released. And after that we have created this cavity, we're going to inject a small amount of fat, not as much as a fat graft but as a spacer to prevent readherence of the dermal attachments, much like Tim is using the fat graft interposed to the corrugator muscle to prevent readherence of the tissues that have been released. And that actually is much more powerful than any facelift technique in the nasolabial area. There's no facelift technique in history which can deliver a correction of the nasolabial fold which is as powerful that you can get by combining microfat grafting with subcision. And this is not an exception. So that is 14 months postoperatively. This is a stable result. And so she only had fat grafting and subcision of the nasolabial fold and Botox to her brows. She didn't have a facelift. She didn't have eyelid surgery. And you see how much that makes her look reposed and healthy just by correcting this this perioral area. Of course, fat grafting of the lips is something which we do a lot. We want to avoid exaggeration, but I think with fat grafting you have to understand and counsel your patient that due to the mobility of the lips you get a lot of resorption, and that the patients, when they have a certain volume in mind, if they really want an augmentation of their lips, they will have to come back, I think, or at least two times, or most of the times 3 times to get a proper volume. And you should microfat the whole upper lip, not only the white roll, but also the vermilion. We fat intradermally or for the perioral rhytids, the white roll and the philtrum. Resurfacing can be added to that, and lip lifting if it is necessary. So in this patient, we treated her perioral area with microfat grafting of her vermilion, sharp needle intradermal fat grafting of the perioral rhytids, and lip lifting. And the combination of these 3 components delivers a true rejuvenating aspect of the lip. In this patient as well, we combined fat grafting of the lips with lip lifting, and the idea is that fat grafting gives you projection of the lip, where the inversion of the lip needs to be obtained by shortening of the vertical lip height with a lip lifting. And this will give you a good, better shape of the upper lip without adding too much projection. You don't want to obtain this projection with just fat grafting, because then you will grossly deform the lip. And this is just another example of a perioral rejuvenation combining fat grafting, lip lifting, and laser resurfacing. So centrofacial rejuvenation changes or restores the facial expression of the face. This lady looks tired, sad, whereas she had a very smiling face before. So this is the combination of a max lift with augmentation, blepharoplasty, and perioral rejuvenation, also a lip lifting. This is her 1 year postoperatively, and she is not smiling on this photo. This is just the corners of her mouth that have lifted a little bit, her lip which is a little bit shortened, and the aspect of her orbit which is more relaxed and also less tired. So it truly changes the basic emotional expression of the face. In this patient as well, I always ask my patients to bring pictures of their youth to guide me where I want to go with the rejuvenation. You see that the combination of the correct tools, the max lift for correction of the laxity in the jowls and the submental area, the temporal lifting for correcting the temporal hooding, the pinch lower blepharoplasty to get rid of a little bit of skin excess, and then microfat grafting in the upper eyelid crease, in the malar area, the marionette grooves, and the chin have actually created a facial expression which is much more reposed, much more relaxed, healthier than what she was before. She is not smiling on this slide. She just has a more relaxed, basic facial expression than what she had before the surgery. And just to illustrate this, how powerful fat grafting can also be in the chin, it allows you to very effectively sculpt the chin, not only in the anterior-posterior direction, but also in the vertical and the horizontal direction. So it's a 3-dimensional tool for facial sculpturing. This patient, 62 years old, came to us after a previous facelift done elsewhere, asking for a redo. And actually the facelift, the max lift that we did, has improved a little bit. It has improved his jowling, it has improved his neck, but the biggest improvement has come from the fat grafting in his mid-face. And so that has allowed to invert the basic triangle of age to the inverted triangle of youth, and this is a 1 year postoperative result. Again, a lady with a tired look, 46 years old. She had an upper and a lower blepharoplasty, but fat grafting in the orbitomalar area, in the nasolabial fold, the upper lip, and this is her 9 months postoperatively. And after 4 years, she actually looks better than after 9 months, and that has probably something to do with the effect of regeneration that you get with fat grafting, which is actually even a better reason to incorporate fat grafting in your armamentarium. So you see also the inversion of the vector from a negative to a neutral or almost a positive vector by fat grafting the infraorbital area. And then finally this 50-year-old gentleman, does he need a lower blepharoplasty? Of course he does. But if you would only treat him with a lower blepharoplasty to start with, you would have a very hard time not to create a situation where you can get a scleral show because he has a very negative vector, but you would actually undertreat him. So he was treated with 25 cc's of fat in each orbitomalar area and only pinch blepharoplasty with a suspension of the orbicularis just to prevent ectropion in the early postoperative period. And this is 1 week postoperatively, and he is a little bit overgrafted. That is a fact. And after 6 weeks, when the edema goes down, he already looks a lot more normal. And this is him 9 months postoperatively, and 4 years postoperatively. The result is stable. He has gained a little bit of weight, which has made up for the difference between the 9 months and the 4 years aspect. But he looks much more relaxed and healthier than he looked before. And it is impossible to obtain such a natural and satisfying result just with a resectional eyelid correction. So does it help for the longevity of your results? I'm convinced it does. This lady was one of our first max lift candidates. She was 45 years old when she came to us, just complaining of a little bit of jowling, a little bit of submental laxity, not much. So this is her 6 years after her simple max lift, just the max lift without anything else, and it's still stable. She still has a good jawline, she still has a good submental, cervical mental angle, but after 10 years, she has, I think, the right to have some relapse of her jowling. Apart from that, you also see that she has lost volume. She has lost volume in her premalar area, she has lost some volume in her upper eyelids as well. So 10 years after her initial max lift, we redid a max lift together with some fat grafting in the perioral and the periorbital area. So this is her 1 year after her second max lift, together with microfat grafting. I think we see several things here. I think for to start, we see that she doesn't look like a re-lifted patient, as we have seen them for many decades after repeat traditional skin facelift, which flattened out the face and gave a windswept appearance. She still looks very unoperated. But also we see that she's actually looking better because we have replenished her midface, we have replenished her periorbital area, and also improved a little bit the fullness in her perioral area. And this is 3 years after her second max lift combined with microfat grafting. So this microfat grafting adds to the longevity of your facelift and will also allow you, in many cases, to extend the time that the patients don't need a redo lifting operation. So this is the 3 years post-op after her second max lift, and this is her initially after her first, before any surgery. So the longevity can be improved with volume restoration. The neck may need some more work, but repeating a max lift after max lift is no problem. So to conclude about the ideas on centrofacial rejuvenation, I think centrofacial treatment is an absolutely essential component in comprehensive facial rejuvenation. The midface ages by deflation and not by sagging. And midfacial descent is for the biggest part an optical illusion. An empty midface does not have to be lifted, but has to be filled. And microfat grafting of the midface is a quicker and safer and less invasive way to get rejuvenation than any midface lifting technique. Thank you very much for listening.